and welcome to our first virtual Lupus Health Conference of 2023, presented by the Lupus Foundation of Northern California. My name's Tom Bakewell, and I'm excited to be your host today. I joined LFNC in February of this year as the interim ED. The plan is to transition into a full-time role in June. This organization is an honor to work with, and we are excited to kick off our conferences of 2023 today. Today, we welcome each of you back to our free Lupus Health Conference. We have two great sessions planned for today. We'd like to thank AstraZeneca and Aurinia for being sponsors of today's health conference. Although the next health conference will also be a virtual event, we're looking to host a hybrid event in Sacramento in May or June. Be sure to follow our social media accounts or sign up to receive our emails so you can get the most up-to-date information. We'll also be hosting our 29th annual Outrun Lupus 5K on Saturday, September 23rd of this year at Campbell Park. More details will be available shortly. This will also be a hybrid event, so you can join us from wherever you live in Northern California or beyond. Start thinking about forming a team and help us outrun lupus. So we want to hear your thoughts on this conference today, so be sure to complete the survey when the webinar ends. This is the only way we can hear what you liked and any suggestions for what you'd like to see in the future. So now I'm going to go over the agenda quickly and then we can get started. The first hour, Dr. Neuwelt will discuss SLE diagnosis and treatment, followed by 15 minutes of live Q&A. You can ask a question by clicking on the Q&A button in your Zoom window and typing your question, either during the presentation or during the Q&A session. You can ask questions anonymously by clicking the checkbox next to your question before clicking submit as well. So please don't hesitate to ask questions. We'll be moderating the questions so you can type your questions whenever you want during the presentation. After the Q&A, we'll welcome Dr. Elizabeth Clayton. She'll discuss bringing lupus nephritis out of the shadows, followed by a Q&A session. Okay, now that we've got the administration stuff out of the way, I'm pleased to introduce our keynote speaker, Dr. C. Michael Neuwelt, Director of Rheumatology, Core Curriculum, St. Mary's Medical Center, San Francisco, California, and the Director of East Bay Rheumatology Research Institute in San Leandro, California. Dr. Neuwelt has been challenged and fascinated by SLE since 1973 during his third year of medical school. This challenge and interest has persisted throughout his 43 years in clinical private practice, which began in 1979. Dr. Neuwelt was also the first Purple Ribbon honoree for outstanding commitment to lupus treatment and research from the Lupus Foundation of Northern California. We're thrilled to have Dr. Neuwelt here to talk to us today. Welcome, Doctor.
Well, thank you very much. You're thrilled and I'm honored to be able to give this talk, because I think it's a very exciting time to be working with lupus. In the beginning with lupus, we had trouble getting positive studies and better treatments, but over the last several years, there's been 3 drugs that have had approval for lupus for different manifestations of the disease. Now, what you have to understand is lupus is a complex disease, which all of you know. It has various clinical features, which I will show you. It has different diagnostic and classification criteria. And then, excitingly, it has different immunological presentations, which we can target. And there's actually been 3 new indications and 2 new drugs for lupus. And people always ask me, why did you start liking lupus? I started liking lupus because I found it fascinating and challenging. And now, many years later, I find it still fascinating and challenging. Now, as I said, numerous factors may cause this disease. We have to initiate autoimmunity, which means our cells fight ourselves. There's genetic factors and there's environmental factors. Certainly, 2 of those are hormones and infections. The system gets immune reactivity by both the innate immune system and the adaptive immune system. And from that, we get the production of autoantibodies, cytokines, and it can affect many different parts of the body: the skin, the joints, the lungs, which are three of the most common, and also the brain, and then the kidneys, which I think you'll hear more about. But again, that's a very important manifestation of lupus. And through all this, there's autoimmune amplification. Now, how about heredity in lupus? Let's figure out now, why do some people get lupus? A child's risk of developing SLE if their mother has disease is 1 in 40 if she has a daughter, and 250 if she has a son. As we know, lupus is predominantly a female disease, but we certainly do get males with disease. And when males get it, sometimes it can be more severe. Now, epigenetics is environmental factors that trigger this gene and cause people to have lupus. It probably occurs from a genetic predispositions in 2/3 of the risk, and environmental factors in 1/3. Now, what are these environmental factors? Smoking, which we really know now is a major cause of rheumatoid arthritis, a cousin of lupus, Epstein-Barr virus, CMV virus, silica exposure, pesticides, and gut microbiome. Now, the risk in white females of catching lupus is 1 in 1,000. If you're an identical twin with lupus, you have a 25 to 50% chance of developing the disease. Now, think about that. That really points to genetic factors. A non-identical twin is 2 to 5%. Again, emphasizing heredity, etc. And if you are a first-degree relative, you have a 6-fold higher risk and more likely to be ANA positive. And that's important because I get referred a lot of patients that have a positive ANA. They don't have anything wrong with them, but they tell me their mother, their cousin, their aunt had lupus, and that makes it more likely that they would develop a positive ANA. Now, epigenetics, as I said, caused by external or environmental factors that switch genes on and off. What are epigenetic factors? An example is DNA in African Americans make their T cells more pro-inflammatory compared to others. And we do know that lupus is more common in African Americans. Hey, what is lupus? Well, lupus is hard to define. It's a progressive autoimmune disease. We get inflammation, tissue damage. What makes it such a tricky disease is there's flares, there can be spontaneous remissions and relapses. And as we know, it's a chronic disease. Most of the time, it doesn't go away. And as I've already shown you by that cartoon, it can affect many different parts of the body. Now, let's get into the classification criteria, because I talked about the complexity of the disease, the classification, and then the good news we can get in this day and age to the different pathogenetic mechanisms and treatment. Now, this was the slick revised criteria, and it took 40 years to revise the criteria. Because remember, when we want to treat lupus and do studies to treat lupus, we want to make sure we're dealing with the same entity, because there's a lot of overlap with other diseases, et cetera. And if you look at the column on the left, you can see the various clinical manifestations. And I just want to make sure I just go over 3, because that's what we most commonly see when we do clinical trials. And serositis or pleurisy is one, acute cutaneous lupus, and arthritis are the 3 most common manifestations. When we talk about immune criteria, well, the ANA always has to be there, usually in a titer of at least 1 to 80. DNA SN stands for Smith, phospholipid antibodies, complements, and the direct Coombs test. Now, here is the newest criteria for lupus, which came out in 2019. It's a little bit different because it breaks them down into different categories and different immunological domains. And you can see here on the left are the clinical criteria. And here you see the hematological domain of low white count, platelet count, autoimmune hemolytic anemia, where your red cells are destroyed by autoantibodies, and then the renal domain, which is very, very important. And you'll hear about that more in the next lecture. There's immunological domains and the phospholipid domain, that's that antibody, which can cause clotting in the patient or can lead to miscarriage. Complements in various combination can be low. And then we have the highly specific autoantibodies, the DNA and the anti-Smith. Now, classification criteria are not diagnostic criteria. Now, that's very important to understand because in clinical medicine, we don't go through all these criteria. It's more of a clinical diagnosis made by an experienced doctor to decide, yes, you have lupus, no, you don't. So they're not diagnostic criteria. Most importantly, if you get the ANA, it should be positive in a titer of 1 to 80. So a 1 to 40, we don't really count. It has to be 1 to 80. And in order to make the diagnosis, they have to have 10 points, which you see these points here. Items can be counted for classification if there is no more likely cause. Like a lot of people maybe have problems, but it's caused by other drugs they're taking. Only the highest criterion is given a domain count. For example, if you look at the neurological domain, which is the most confusing, and seizure, that gives you the neurological domain, but you don't also count if they have psychosis or delirium. And SLE classification points from at least one clinical domain. So you can't make the diagnosis just from the laboratory. There has to be one clinical finding that are on the left that give you this diagnosis. Now let's talk much more specifically about the ANA, because it's the one that leads to the most confusion. And sometimes when patients come in and they say, well, why do I have a positive ANA? And I'd say, well, as I said already, maybe one of your family members has lupus and your positive ANA doesn't mean anything. And it's usually positive in about 99% of patients with lupus. So if the ANA is not positive, that's kind of rare. But the problem is the ANA is not a specific test for lupus. So we need the clinical criteria or more specific autoantibodies. Now, how about that? What are other conditions that are associated with positive ANA? Well, I gave you lupus is very high. Drug-induced lupus, it's 100%. And there the autoantibody is also the antihistone antibody. Mixed connective tissue disease, scleroderma, polymyositis, dermatomyositis, Sjogren's, phospholipid antibody syndrome, and RA. So you can see the ANA doesn't just mean lupus. It's seen in other of our autoimmune diseases. Now, other diseases, autoimmune liver disease, 100%, thyroid, almost 50%, multiple sclerosis, 25%, primary pulmonary hypertension, 40%, chronic infections, tuberculosis, mononucleosis, subacute bacterial endocarditis, and cancer and lymphoma. So you have to make sure when you, and I get referred a lot, patients with the positive ANA, they don't have any of the clinical features of lupus, which I showed you on a previous slide. And I'll say, well, it doesn't mean anything. Or they tell me a family member had lupus, and that explains why their ANA was positive. Now, how to interpret the ANA? 4 things to look for. Now, what test was done? Was it immunofluorescence or was it ELISA? And as the immunofluorescence is the gold standard, and it's the one that we do in all our clinical trials and the one you should insist on. And then the idea is it's either present or not. Okay, so to make a diagnosis of lupus, it must be present, have a titer, which means a number as you dilute it of 1 to 80. It has a certain pattern, which sometimes can lead you to subgroups of lupus or other autoimmune diseases that are associated with ANA. And the measure of the quantity determines if it's clinically significant. So there's 1 to 80, you double it, it's 1 to 160, 320, 640, and 1280, and you get up to 5,000. But the key is it starts at 1 to 80. And that's a very, very important concept to remember. Now, we measure it 2 ways. We either measure it by the immunofluorescence or by the direct testing. And the problem we get into is the direct testing is 8 to 10 times cheaper, but less informative. And, when we now live in a world of large labs, Quest, LabCorp. So it only tells you if it's present or not. There's no info on pattern, increased risk, false negative, and false positive. And as I said before, the indirect immunofluorescence is the most common gold standard. It's good as first screening test. It tests different antigens over 100. It tells if ANA present, pattern, and titer. So certainly, if in a setting of a clinical trial or if a patient really wants to know, then we should, usually what I do is I send off the ANA and do it by indirect immunofluorescence. Now, how about the titer, which is the quantity of it? And I've already talked to you about the dilutions as it goes up. And as I've already emphasized to you, to be clinically significant, it has to at least be 1 to 80. So 1 to 40 does not have any clinical significance. The higher the titer of the ANA, the more likely there is pathology associated with it. Not necessarily, it just says more likely. Can ANA be detected in normal population? Yes. 20 to 30% of healthy individuals and up to 70% in people older than the age of 70 can have a positive ANA. 1 to 80, 10 to 15% are positive. Over 160, 5% are positive. 320, 3%. So one of the more common titers we see is 1 to 80, because as you get higher, it's less likely to be positive. Healthy relative of a patient has a 5 to 25% chance of having a positive ANA. Now, we spent a lot of time talking about the ANA, and you can see here at any time it's 76% positive at onset, and then at any time 94%. How about the double-stranded DNA? At onset, maybe 34%, and then at any time, 71%. Now, what are other lab tests that we tend to do when we are analyzing a patient for lupus? I'm looking at that CBC. I want to see if they have anemia, whether their white count is low, whether their platelet count is low. I want to make sure their renal function is normal. I want to look at their urine and the microscopic to make sure they don't have inflammation in the kidney. And now that's very important, because if they do, that's not something you feel, but that suggests that maybe they have lupus nephritis is the word. We look at the 24-hour urine and see how much protein they have, if they have a positive protein on the dipstick. We also know that low complement levels correlate with disease activity. The SED rate and the CRP give you disease activity, but they're not always positive in lupus. What's more important are the immune tests, which I talked about. And then the antiglobulin tests are seen in people with hemolytic anemia. Now, there are links between different antigen and antibody and prevalence and main clinical features. Now, the double-stranded DNA is one of the most important, and we can see that in kidney disease and skin disease. So if a patient has a positive ANA greater than 1 to 80 and a positive DNA at a significant titer, we know that perhaps this is lupus, and we look for different manifestations. The nucleosome is seen with kidney and skin. The rho is seen with kidney, skin, and fetal heart problems. Now, the rho, or the SSA, is very important because lupus is more common in young women. And if they have the rho antibody, that antibody can cross the placenta and cause neonatal heart block. So if a mother of a child has a positive rho, we want to make sure that there's a pediatric cardiologist available to treat that heart block. The LA is seen also with fetal heart problems. The Smith, kidney disease. Phospholipids is clots in the patient or pregnancy loss. So I'm always asking, have you ever had a miscarriage? Here we have the actinin, which is seen in kidney disease, and the C1q. Now, variability of presentation. Now, I think this is a very important concept here because it happens to me every day, every week, every month. 47% of patients with presumptive SLE are referred to an autoimmune disease center from the community, only had other diagnosis. So a positive ANA itself is insufficient to establish diagnosis. And we want to see the other multi-system characteristics. Now, here is a good example. This young lady, this is lupus of the skin. She has arthritis and rash. And notice it spares these nasolabial folds. Now, here's another patient that has fibromyalgia that has a positive ANA, early rheumatoid arthritis. And this rash is not the rash of lupus, but it's acne rosacea. And, if you're not sure about the rash, you send them to a dermatologist, because clearly lupus is a disease where you need the help of many subspecialists, not just dermatologists. You need a cardiologist, you need a pulmonologist, you need a kidney specialist if they have involvement of the kidneys. Now, clinical manifestations vary by race. And you can see that in the dark here is the Caucasian, African, American, and Hispanic. And there's a disproportionate amount of lupus in all these organ systems that race is very important. And that's one of the things that I always established if it's not clear to me, because that will make a difference in how they do. If you look at the renal here, as you can see, a lot less Caucasians develop renal involvement than do the other races, ethnic groups. Now, this is a very important concept, which I have residents that come to my office and I teach them about rheumatology, and I happen to see a lot of lupus patients. And the rate of mortality is high relative to the general population. So here you're taking patients aged 16 to 24, and it is almost 20 times greater than the general population because they have lupus, and lupus can predispose to cardiovascular disease. It's 8 times greater, 25 to 39. The numbers get smaller because as general population gets older, they're going to have a little bit of lupus or other problems too. And here you see the lupus patient 3 times 7 from 40 to 59 and greater than 60, it's 1.4. So this disease is important, and no matter what the age of the patient, if they say they have chest pain, pressure on the chest, or they feel their heart is beating funny, you want to send them to a cardiologist. Now, how about some of the non-specific manifestations of SLE? There can be fever. There can be unexplained weight loss. Not Jenny Craig or Weight Watchers. These people just lose weight and they don't want to lose weight. Now, there's fatigue, myalgia, lymphadenopathy, and Raynaud's. And of all of these, which one do you think is the most common and the hardest to treat? Ding! Your time is up. I didn't see anybody answer that. And if they did, they were pretty fast. Fatigue is a major problem with lupus, and it's a different kind of fatigue. People sleep. It's not caused by insomnia. They're not depressed. And they wake up in the morning and they feel fairly good. And then in the middle of the afternoon, all of a sudden, they run out of energy. And we know that fibromyalgia patients are tired all of the time. So fatigue is something that is a very prominent feature of lupus, and it's one of the more difficult non-specific manifestation that we have to treat. Now, show you some examples. Here is the malar rash of lupus in a Caucasian, and here in an African-American female, and you can see the butterfly rash. Here's discoid lupus, where there's a thickening of the skin. And here you see it on the scalp, on the face, and here you see it on this young lady's knees. Oral ulcers. And if you look right here, you can see this oral ulcer. Now you look for other things like infection, but that's very characteristic of a lupus ulcer. And here you see some ulcers on the lips. Now, alopecia. Now, one of the things that I've learned through all these 43 years of practicing, if I'm working in a clinic, and whether the days I used to teach the county hospital or in my office, and on a warm day, I see a patient with a hat on, or on a cold day, I ask them, would you mind taking your hat off? And most of the time, they're going to say, sure, doctor. And sometimes what you see is this alopecia, or you see it here, this focal alopecia in this area. Or other times, you look at the scalp and you see the discoid lupus rash, which damages the skin and they can't grow hair there. The important thing about the word damage is it can't be fixed. I mean, you wouldn't take a lot of medicine to try to fix this if that was their only manifestation, because the scalp skin has been damaged and will not grow hair. If If it's going on, though, if it's still active, you would. Now, here you can see this. Now, these joints are swollen. These are called the PIPs. And that's something you might see in a patient with lupus. Or look at this. See these boutonniere deformities? Well, if somebody saw that, they say, oh, they must have rheumatoid arthritis. Well, first of all, just to make it fun, and it's a fun word to use, a small percentage of patients have rupus. Rupus is an overlap of rheumatoid arthritis and lupus. But in this patient, they have pure lupus arthritis, and these deformities are reducible. You can press down and straighten out because it doesn't involve the articular cartilage. You don't see loss of cartilage. You don't see erosions. It's from soft tissue inflammation, and it leads to these deformities. Now, how about the central nervous system? Well, this is an area that I have a lot of interest in, and was involved in multiple publications about neuropsychiatric lupus. And there's many different types: diffuse cerebral manifestations, psychiatric manifestations, including depression, but you have to sort through. Do you think that depression is part of lupus, or is it a secondary cause? And that can get difficult. Cognitive impairment. Well, many times you want to do neuropsychological testing if it's significant, because we know patients have cognitive impairment when they're depressed, and patients with fibromyalgia get some cognitive impairment. Seizures, and you want to make sure nothing else is causing the seizure. Headaches is very difficult to decide. Is that part of lupus, or is that a secondary manifestation? Focal manifestations that might look like stroke also could be different. Now, one of the things there, we might get an MRI and check the phospholipid antibody. And if the phospholipid antibody is high, one might think that the manifestation and the pathophysiology of that is a clot. And then it can also involve the peripheral nervous system. So very tricky area to study. And we really have not had a good prospective randomized trial about neuropsychiatric lupus. How about the heart? Well, this has become much more important, as I referred to earlier, because heart manifestations obviously can be at times serious. There can be fluid around the heart. There can be inflammation of the heart, myocarditis, high blood pressure, coronary vasculitis, Liebman-Sachs endocarditis, which sometimes can be caused by those phospholipid antibodies that leave clot on the heart valves, and valvular insufficiencies. Now, lupus patients have a 7 to 10 times increased risk of coronary heart disease and stroke. So every patient I see with lupus, if they're 15 or if they're 75, I take anything that might suggest a cardiac manifestation very seriously, and I send them to a cardiologist. Now, this is a very important concept that we're learning more and more about. In the inflammatory state, HDL may lose their protective capacity and become pro-inflammatory. Here you see anti-inflammatory, and here you see pro-inflammatory, AP-HDL. The presence of AP-HDL makes a lupus patient anywhere from 8 to 10 times fold increased risk of having atherosclerosis. It's another risk factor. It's another risk factor. RA, it's approximately a 5-fold increase. In lupus patients with evidence of atherosclerosis, 90% have this pro-AP-HDL. And the presence of pro-inflammatory HDLs is likely in the future to be a good measure of propensity to develop atherosclerosis independent of the lipid panel. So it's something that we try to tease out and figure out in a patient. And if you look at the pro-inflammatory HDL, here you can see 45% in SLE, 20 in RA, and 4 in the control group. So this is a concept that's very, very important and one that we should take very, very seriously. Now, how about the lungs? Well, you can get pleurisy, fluid on the lung. You get pericarditis, which is fluid around the lung. You can get pneumonitis, which is just an infiltrate, or you can get alveolitis, which is a much smaller little infiltrate. You can get pulmonary hemorrhage, which can be very serious, pulmonary fibrosis. And we now have drugs that can help prevent pulmonary fibrosis in patients with lupus. There's a shrinking lung syndrome. They can get pulmonary emboli. And of course, as soon as you hear pulmonary emboli, in situ thrombosis, all of you listening are thinking, oh, that could be related to the antiphospholipid antibody, right? You all thought of that. And then on the bottom here is pulmonary hypertension, which can be very serious. But again, we're developing better drugs for that. So not only as I get into treatment with drugs for lupus, we have better drugs to treat some of the complications of lupus so that we can control that. And that's why lupus patients are doing much better in 2023. And here's an example of a pleural effusion in a patient with lupus. Many times it's asymptomatic. These people may present with chest pain or shortness of breath, and they have fluid. And when we look at the fluid, it has certain characteristic cells. Now, so this is an important one, and you'll hear a lot more in the second presentation. And the amount of renal damage can predict renal failure and mortality. And 5 to 10% of lupus nephritis patients go on to end-stage renal disease. In one study, a quarter with early renal damage versus only 7% without early damage died within 10 years of initial assessment. And this slide over here shows red cells when you're looking at the urine and you see what we call red cell cast, which suggests that there might be inflammation in the kidney. Now, I've talked about all of these, and just notice on the top the ANA, and these are the various manifestations. And as I said, arthritis and skin of the clinical manifestations are the ones that we see most often. Now, how do we treat SLE? Well, one thing I always tell my patients as they're walking out the door, use sunscreen, high temperatures or low temperatures, physical therapy, occupational therapy. We use medication, counseling, and sometimes patients need surgery. For like, let's say, they develop a collapse of the bone in the hip and they may need a hip replacement. We use vocational rehab, exercise, diet, and certain vitamins, and we try to manage their fatigue as best we can. Now, here is current standard therapy, and it includes arthritis, fever, pleurisy, pericarditis, and cutaneous skin. And you can see that these are drugs. That's a way to protect the skin, anti-inflammatory, steroids, methotrexate, leflunomide, thalidomide, anti-malarials. And I have almost all my patients on hydroxychloroquine. It helps control the disease. It helps some of the manifestations. It helps prevent some of the cardiovascular manifestations. And the important thing is it's safe during pregnancy. It's the one drug I keep lupus patients on when they're pregnant. We have topical steroids and other agents, and we can use physical therapy. Now, you might recognize this sitting on this bed, but This gentleman in the movie Lost in Translation is Bill Murray. And also in this movie is Scarlett Johansson. And there was loneliness. They were in insomnia. They were in culture shock because up until 20 years ago, we had not come up with a new drug to treat lupus. And in this modern Asian city, this guy's sitting at the bedside, waiting for something to happen on the bench. And finally, it did happen. And we'll talk about that in just a second. So you can get kidney involvement, inflammation of blood vessels, the lungs, the brain, the blood cells themselves, platelets, and white blood count. Now, what's the treatment of lupus that we've been using for many, many years? And this is what I did for many, many years. Steroids, cyclophosphamide for severe disease, but has lots of side effects, azathioprine, mycophenolate mofetil, which is used a lot in renal disease, cyclosporin, IVIG, occasional patient with severe disease, plasmapheresis. We use rituximab. Now, look at this, recently FDA approved. I've been waiting 43 years to be able to give a talk like this, because I can tell you, I have more tools in my toolbox now to help lupus patients. The first one to come was belimumab or Benlysta for general lupus, and recently it was approved for renal lupus. Anifrolumab or Safnello is good for general lupus. It has no indication in lupus nephritis. And then voclosporin or lupus has been approved and is only used for lupus in the kidney. And if you take the long history to have 3 drugs approved recently, it's quite a change. It's a good time to be a lupus doctor, and it's a good time if you have lupus to be able to have drugs that can make you feel better. Now, as I said, belimumab or Benlysta was approved in 2011. It was innovative. That 50-year gap was finally stopped. It allows you to lower the steroids, because in lupus, there are flares and remissions, and the 2 things that cause the most damage are the lupus itself and the drugs we use, and certainly the steroids cause a lot of damage. The toxic medications we're currently using, whether it's methotrexate, azathioprine, Cellcept, mycophenolate, and belimumab or Benlysta has a very acceptable profile. So what does Bliss-BAFF do to B cells? Well, it's a B cell simulator. And here you can see in normal people, we have this, the immune system serves a purpose, to get rid of foreign things. But in lupus, there's multiple Bliss, which is a cytokine, and it blocks apoptosis or cell death. So consequently, B cells go up. And Benlysta blocks this blocker. Consequently, the B cells go down, and it's a way of decreasing the activity of lupus in someone who is active. Now, let's go to the present, because all of us who take care of patients with lupus have been waiting a long time. The FDA approved agents for lupus in the kidney, and 10 years ago, they approved belimumab for general lupus. But here is an article talking about belimumab and voclosporin or Safnello, which are used in the kidney. And they make a big difference in maybe making that kidney problem better. Remember how I said how bad the kidney involvement could be? Well, these drugs are being used, mostly added on to the standard of care that we've had, and have made a difference. And this drug, Lupus, it gets rid of calcineurin. And calcinurin's job is to activate T cells. And lupus binds to that calcinurin, brings it down, and it makes the inflammation of the kidney better than the standard of care. We still use the standard of care, but we can add this and make it better. And here you can see various features of lupus. And I think the important thing is an improved response rate across a lot of patients with lupus nephritis. Now, how about Safnello? This is a very important drug. I know this drug for a while because we had a lot of patients in this study. It was approved for moderate to severe lupus in August of 2021. And it was the third therapy for lupus to receive regulatory approval since 2011. So as I said, 2011 breakthrough, the glass ceiling was broken. Took us 10 years to get some more drugs. And this drug is very, very effective for general lupus. And how does it work? It binds to the type 1 interferon signature found in many lupus patients. And it's the main receptor that gets blocked to the IFNR receptor on interferon. So here we're talking about a different mechanism that causes lupus. And maybe we'll learn which patients should have those B cells depleted, such as all the drugs we use, or maybe they need to have this type 1 interferon reduced. And just to show you, and these are some of the drugs that are in the lupus pipeline in 2023. And you can certainly find these, you find these online. That's where I found this table. I don't have time to go through it, but just to see, look how exciting that is of all the different drugs that are being tested for lupus. So I talked about Bill Murray and Scarlett Johansson, who were lost in translation. They got scowls on their face, but they're sitting and they're happy. And at this point in time, lupus is no longer lost in translation. And with that, I'm going to stop. It's an exciting time for doctors to treat lupus. And I think if you have lupus, it's a time of great hope for drugs we have and those that will come out in the future. Thank you very much. And I think we have some time for questions.
We do. And Dr. Neuwelt, thank you very, very much. That was informative and very comprehensive. So now we're going to open the Q&A portion of the event. We're going to start with the questions that have been submitted during your discussion. But feel free to ask any additional questions now, and we'll try to get through as many as we can live. But if we can't get through them, we will email you the responses. So there's 4 questions that came in during the presentation. I'm excited because I can answer one of them. That was the easiest one, which is, will the presentation be available online in the future? And yes, it will. We're recording this presentation. We'll put it onto our website and then send an email with the link out to all the participants, and you'll be able to view this again. And so now here are the questions, Doctor, that came in. What is the risk in the general population for Black women?
It's much higher. I wish I had an exact number for you, but it's about, all I can tell you is it's 10 times more frequent in Black women than it is in non-Black women. Okay, that's the closest number I can give.
And so forgive me for butchering this word, which I'm going to tell you I'm going to do in advance. Is dysautonomia symptoms common in SLE patients?
They can be. Yes, they can. And, it's not seen that commonly, but it can be. Most things that happen, if you look at case reports, you can see examples of that. And that is one that can happen. Yes.
Thank you. And the final question that came in during the presentation is Plaquenil not a standard treatment anymore?
Well, the answer to that is just the opposite. it's still a standard treatment. As I said during the presentation, I keep almost all my patients on hydroxychloroquine because it's safe in pregnancy. It helps treat that fatigue, which is difficult, the skin, the joints, and it helps prevent flares. So I would say almost all my patients are on a baseline of hydroxychloroquine. Just because we have these new drugs, sometimes we use them as an add-on to the drugs that people are already on.
Okay, thank you. Those were the questions that came in. If there's any other questions online, please go ahead and put them in the chat. Okay, we just got one. This will take me a second to read. It's a bit of a long question, so bear with me.
Oh, I like long questions.
At my time of SLE diagnosis, I had an ANA off the charts, 1 to 1,280. Once on treatment, the titer decreased but remained positive. 20 years on treatment, however, my ANA is now negative. Is this possible with lupus, or does this indicate I may now have been misdiagnosed?
Well, I would say more likely than not, as people have lupus and they're treated, many times the positive ANA can go away. And I think that can happen, or sometimes just with the natural history of lupus, because it has so many flares and variabilities, it can go away. I would say if a long time ago they said you had lupus and you had not just the ANA, but you had those clinical features that I talked about, because I remember I emphasized you can't make a diagnosis of lupus just with the ANA, that, perhaps you had lupus and now it's no longer active and you no longer have a positive ANA. But but the ANA could come back. That it's either positive or negative. And if it was positive and they made a diagnosis, then perhaps you're doing better and the ANA is no longer positive.
Thank you. And I think that the final question that we can take live today is, can you talk a little bit more about treatment or management strategies for fatigue?
Well, I knew somebody was going to ask me that. And I think that, first of all, if you go through the different drugs we use to treat lupus, many patients are started off on prednisone. And I usually start 5 milligrams twice a day. And many times that can help their fatigue. And also we look for other causes. Maybe they're not sleeping well, maybe they're depressed and they need an antidepressant. But I have found, and very interesting, that the two drugs that are fairly effective for fatigue are two of our new ones, belimumab or Benlysta and Safnelo or anifrolumab. And I have found that patients say, yeah, my fatigue is better. Now, with anifrolumab, remember, it's given IV. Now, you sometimes wonder, well, could that be a placebo effect? Because they come in, they get an IV, and maybe psychologically they feel better, and that makes their fatigue better. But in my experience, and I have a lot using both those two drugs, I think they are more helpful than the other drugs that we have to fight the fatigue of lupus.
Okay. Is there any more questions? We have a few more minutes. I might have jumped the gun there a bit. If there's any more questions. Okay, I do have one. How soon can patients expect to get CAR T cell therapy for lupus? That's the first part of it, and there's a second question in a minute.
Well, I assume CAR T therapy means that it's specific for their disease and, by their markers and everything. And I think that's coming fairly quickly. And I would say in the next 5, at most 10 years, a patient will be characterized by what kind of lupus they have and what might be the best drug. I would say that I always think of rheumatologists as mini oncologists. And we're sort of following many of the things that they do, because we can look at the their genetics. We can look at their clinical features. There's other markers now that are coming out, and it might tell us, well, no, this drug is best for this patient. And I think that's where we want to go, through genetics, through clinical features, through other disease markers, and decide, hey, this is the best treatment for this lupus patient. And I think that it's being done, we'll be there, and it's kind of an exciting concept of having enough tools in the toolbox that you can match a patient's history, genetics with a certain drug or treatment.
And then there's a couple follow-on questions from her. Can patients participate in trials now, or is this something they have to wait for in the future?
Oh, I think patients can participate in trials now. I don't know why they would have to wait for the future. No, there are a lot of trials going on. And I showed you that whole page of different things that are being looked at in lupus. Now, it may be more difficult than you think to get in a trial because you have to be eligible. Remember that ANA in a trial has to be at the time of starting the trial 1 to 80. And then you have to have certain other clinical features, and you can't have comorbid conditions such as Sjogren's syndrome or rheumatoid arthritis or other things that that would confound the analysis of the patient.
So I'm going to insert a follow-up question on my own on this, which is, how would you recommend they have that conversation with their doctor, their rheumatologist, to get into a trial?
Well, they should tell them that, they want to be in a clinical trial because the medicines that they've been given haven't been helping. And also these new drugs that target certain areas of lupus, to them makes that lot of sense. And then they can look at clinicaltrials.gov. There's clinical trials. We do them here. You could call Stanford and seek a Gittin study, or UCSF. You can, and then there's companies that go around trying to find people that want to participate in trials. So there's a lot of different ways to get involved in a lupus trial, because the more patients we study, we'll get a better understanding of this disease and how to best treat it.
And how soon do you expect FDA approval for CAR T-cell therapy?
Well, I like that concept, by the way. Well, I think that'll take a while, and I'm not sure that'll be a problem because a lot of the drugs that may be involved in CAR T therapy are already available. And then if a study shows that this is available, I think the FDA knows what a difficult disease lupus is. And I think if they can see phase 3 trials that show, hey, this really worked in this group of patients, they're going to throw the car keys out and say, yes, we approve your drug, right? Or your methodology of 2 drugs, whatever.
Great. A couple more questions have come in. I think we have a minute to do these. Given the potential for pro-inflammatory HDL, is low HDL in lupus patients less of a concern than for the general population?
Low HDL in lupus patients is more of a concern because, high HDL is protective, and lupus itself is another risk factor, whether it be the lipids and a low HDL, high cholesterol, whether it be hypertension, high cholesterol, etc. So I think that in that scenario, the answer is yes, and that they want to be carefully worked up for the other risk factors, as well as treating their lupus to minimize their risk of developing cardiovascular manifestations of lupus. It takes a whole team, and certainly being aware of cholesterol control, blood pressure control, etc.
And the final question, doctor, that's come in is, are you familiar with the work in Germany using CRISPR? And if yes, can you talk about this therapy potentially coming to the United States?
I have heard about it, but I don't feel that I know enough about it to comment.
Okay. Last call for any questions. Anyone have any questions they would like to ask the doctor? Okay, not seeing any. Dr. Neuwelt, I got to tell you, we really appreciate your time and expertise. If you want to rewatch this video, like I said a minute ago, it's going to be available on demand next week. So watch for an email with the link. So, Doctor, thank you very much. And I'd like to now introduce Danny Martinez from